All right, welcome to the podcast. Today, I have the pleasure of being here with Dr. Chuck Raison. Dr. Chuck Raison is the Mary Sue and Mike Shannon Distinguished Chair for Healthy Minds, Children and Families, and Professor of Human Development and Family Studies in the School of Human Ecology. He's also a professor in the Department of Psychiatry at the School of Medicine and Public Health at the University of Wisconsin-Madison. Dr. Raison also serves as the Director of Clinical and Translational Research for Usona Institute and as the Director of Research on Spiritual Health for Emory Healthcare in Atlanta, Georgia. So after all of that, welcome to the show, Dr. Raison.
Thank you. Glad to be here.
Yeah. And for those, who aren't familiar with you and your work, could you sort of broadly just describe the kind of work that you do and what your interests are?
Yeah, so I'm a psychiatrist and started life as a full-time clinician, but spent the last 20 years mostly as a full-time researcher working I think we maybe call it mind-body elements that contribute to depression and well-being. So a lot of work looking at links between the immune system, especially inflammation, and the development of psychiatric symptoms like anxiety and depression. Over the last 10 years, I've embarked on doing a series of studies looking at novel ways to treat depression. Interestingly, I say novel, but many of them are actually quite ancient. I sometimes say I'm like the guy going through the junkyard retooling things. So I have this interest in studying ancient practices, things like hyperthermia, heat, psychedelics, things that have been around for hundreds or thousands of years that were often used for spiritual purposes or healing purposes, but that seem to have this real promise as novel antidepressant modalities.
Mm. Well, as we all know, depression is something that's affecting so many people. And I think, some people have found the typical treatments to be effective for them, but other people have found them to not be effective. And so I think that some of the research that you've been doing has shed some light on why, some treatments might be helpful for others and why other treatments might not be helpful for others. So would you mind talking a bit about that and specifically, about the role of inflammation in depression?
Yeah, sure. So right. So as we think about how depression is generally treated let's just stick to the United States for now. The vast bulk of people that come in with the kind of depression that's messing up their lives are put on an antidepressant if they come to get treatment. And the most commonly used antidepressants by far are these things called selective serotonin reuptake inhibitors, or SSRIs. There's similar agents are called SNRIs, like venlafaxine and duloxetine. Those are the lion's share of what people get. The other thing that we know from many studies works just as well is psychotherapy. And people do get psychotherapy, but a lot more people are just put on a medicine. And it's exactly as you said, Nick, that if you look at, I think, the most realistic real world studies, probably 25, 30, 35% of people will get a fully adequate response if you just start them on an SSRI, on an antidepressant. And then about 2/3 of people, they may get a little bit better, but they don't get better enough where they're really in a sort of an optimal position to function or to avoid crashing back into a depression again. And sadly, the more antidepressants people are on, the less likely they are to respond to whatever you try to put them on next. And the other hard thing is that even amongst people that have this kind of a full remission or response, again, I'm thinking about the largest real world study ever done, a study called STAR-D. Only 15% of the people that had gone into the study were still doing well a year later. The vast bulk of people crash and burn, right? So the last 20 years have been a hard time for psychiatry. We've seen for a variety of reasons, we've seen our confidence in the efficacy of standard agents drop as studies have suggested, they're not as effective as we'd hope they are. So then, what are the risk factors for not getting a response from an antidepressant? Well, there's a number of them. The longer you've been depressed, the less likely you are to respond. But you mentioned something which is an area of real interest for many of us, which is the potential that inflammatory processes may interfere with the ability of people to respond to an antidepressant. So there's two really interesting lines of data there. And by inflammation, this is this sort of generally innate immune system activation of those pathways. How do we know about it? We measure some peripheral biomarker, let's just say C-reactive protein, which is easy to get and actually turns out to be quite interesting as a predictive variable. So there are studies showing that people that as your just resting state, baseline inflammation goes up, the less likely you are to respond to an antidepressant. Those studies, of course, the wrinkle there is that most people in those studies are on something like an SSRI or an SNRI. There are more interesting data suggesting that inflammation may tell us a little bit about which agents a given patient is more or less likely to respond to. So there are now several studies suggesting that if your inflammation is elevated, if you have say a CRP greater than 1, which is not that elevated, but if you have a CRP greater than 1, you begin to see this real drop off in the response rate of people to SSRIs, to serotonin and antidepressants, and you see a concomitant increase in response to a dopaminergic, noradrenergic agent like Wellbutrin, which is bupropion, right? This has been shown, this pattern has now been shown in 2 or 3 studies. I wouldn't take it as settled fact, but it's pretty striking. And so, before we started, you and I were talking about my mentor, Andy Miller, who is really, I think, world leader in this space. And what he and his colleagues have shown, following up on some work we did back about 10 years ago, is if you just take depressed people, you, me, you're not sick, you're just depressed, and you measure their inflammation, you measure, say, CRP, you find that the people that are depressed that have elevated inflammation have different patterns of brain function than do people that are just as depressed with low levels of inflammation. So it really looks like inflammation has this tendency to go after dopamine circuits in the brain, to turn down their activity and to sort of disconnect dopaminergic areas like the ventral striatum, these parts that are sort of the reward center of the brain, get disconnected from areas like ventromedial prefrontal cortex, which have a lot to do with assessing the value of reward, feeling the reward, planning about the reward, making effort for the reward. So there really is this suggestion that's increasingly coming into the world that although the subgroups don't have hard and firm boundaries, there's a cloud of depressed people whose inflammatory levels are sort of elevated, and they look different, both brain function wise and in response to psychotropic agents, than people that are just as depressed that have lower levels of inflammation. That is where I think one of the cutting edges of the field is right now.
And you mentioned one of those mechanisms of the role of inflammation being kind of through a circuit effect in the dopaminergic circuits. And then one of the other mechanisms that I know that you've mentioned before is through the kynurenine pathway and the
Right.
production of the quinolinic acid.
Yes.
Is that one of the other main explanations? Are there other explanations you
Yeah.
can
So
think of
there's a
the
right.
mechanism?
So how does inflammation? The larger question is, how does inflammation make you depressed? And
Right.
we did a bunch of studies with interferon alpha back in the day, and everybody would get the same dose, but some people would be kind of bummed out, and other people want to kill themselves. I mean, a wide range of depressive symptoms allowed us to look at what are the downstream pathways whereby any given dose of inflammation makes you more or less depressed. And you're right. So the kynurenine pathway, so tryptophan, is the raw material for serotonin. And depending on how your enzymes are working, tryptophan can either be shunted into serotonin or it can be shunted away from serotonin into these kynurenine being the first, molecule on the pathway that eventually ends up in a couple of things, kynurenic acid and quinolinic acid. Quinolinic acid especially is of interest because it is neurotoxic, and so it's kind of a hot, nasty chemical. And we showed back in the day that when people get interferon alpha, the more their kynurenins go up, and the more the quinolinic acid goes up in the spinal fluid, the more depressed they get. So it's kind of a nice story, and um, a lot of other people have found similar or supportive kind of ideas. So, one of the reasons why SSRIs might not work as well as your inflammation goes up is you're getting more activation of enzymes like indolamine 2,3-dioxygenase, which breaks down tryptophan and instead it doesn't send it into serotonin, it sends it down the kynurenine pathway. That's one. We also know that inflammation impairs this tetrahydrobiopterin, BH4, which is this key sort of contributing agent to the pathway whereby amino acids are converted into neurotransmitters. So tyrosine hydroxylase and tryptophan hydroxylase, they need BH4 to function, and inflammation just tanks it. So there's some evidence in general that neurotransmitters tend to be muted. Inflammation alters the reuptake pump density. It tends to send reuptake pumps out onto the presynaptic nerve terminal. So there's sort of a direct neurotransmitter effect. And then I think one of the things that's most interesting is this idea that under inflammatory stimuli, you get a change in how glial cells interact with neurons. So in particular, there's still some debate. Microglial cells are the sort of the resident macrophage-like cells in the brain, and I think the way the evidence now suggests that peripheral inflammation activates them to become inflammatory and that they are bad guys in terms of your mental state. Not everybody would agree with that, but what does seem clear is that when when inflammatory signals really begin to reach the brain, astrocytes, which surround the synapses of neurons and tend to work like vacuum cleaners to suck up the glutamate, pull it out so that it's only in that synaptic cleft because it's so damn neurotoxic. The astrocytes do something really weird. They kind of reverse the vacuum cleaner and start spewing out glutamate into the non-synaptic or the extrasynaptic spaces. And when glutamate does that, it can interact with non-synaptic NMDA receptors. So, within the synapse, the NMDA receptors combine in complicated ways with AMPA receptors to sort of magnify signaling and develop long-term potentiation. That's sort of how the information seems to be stored. But when you stimulate MDMA receptors that are not within the synapse, they really have the opposite effect. They essentially turn off BDNF. And so you get sort of loss of trophic support. And I personally think, although I can't prove this to you, that from an evolutionary perspective, the reason that happens is it's an evolved mechanism to protect the organism from being sort of manhandled by pathogens. There's all this emerging data on pathogen manipulation, right? And so inflammation is a signal of, hey, you're infected. And certain brain areas that seem to be very involved with sort of decision making tend to get taken offline. And again, I think that probably, although it's a bummer in the modern world, it was a way to sort of dampen down the ability of invading pathogens to drive behavior. It's a really interesting thing. So those are some of the primary ways, biochemical ways, that inflammation does things that we know set not just humans but laboratory animals up for depression or depressive-like behavior.
Mm. And now that you've given this, explanation of a few different ways that inflammation might be contributing to depression, I think it'd be really interesting to talk about the research that you've done with whole body hyperthermia and the impact that may have for treating depression.
Absolutely, and the impact it may have on inflammation.
On
so
inflammation.
This is really interesting. Yep. So I've had a long-term interest in thermoregulation and mood. It turns out that there are very close connections between pathways that run between the brain and the body, both ways, that modulate mood and that modulate, the ability to maintain a constant body temperature. People with depression, and we've known this now for probably 30 years, tend to have thermoregulatory abnormalities. They tend to run their body temperatures hot, especially at night. And the best studies suggest that when you treat them, if their depression goes away, their body temperature drops down back into the range of, like, say, normal control subjects. Depressed people don't sweat. And back in the 80s, there was actually proposals to make like galvanic skin testing, like what they do for lie detectors, a diagnostic mechanism for depression. I mean, crazy idea, but the reason they had that idea was because the depressed people look really different. So depressed people have a difficulty with thermoregulatory cooling and as a group. And so there were a number of us who were interested in this question of whether or not heat might hold potential. I had been interested in some of these really esoteric heat meditation practices engaged in by Tibetan Buddhists historically. And so we had this opportunity starting about 2010 to look at hyperthermia, heat, as a antidepressant modality. We did a first small open trial in Switzerland in 16 people and showed that one treatment, getting their body temperature up to about 101.3 Fahrenheit, 38.5 centigrade, produced a really like a 50% reduction in overall depression scores. And when we measured it, it was a short-term study. We measured it 5 days later. but one treatment and people were feeling like a lot better. So we managed to scrape together some funding and do a larger randomized sham controlled trial in Arizona when I was there. But we had a really nice comparator. We put people in the same machine and we heated them up a little bit and fake lights. And the vast bulk of them believed they'd gotten a real treatment. So it was a nice, the credibility was really good. We showed exactly the same thing. A single treatment produced a rapid and, big antidepressant effect. It's sort of what you see in antidepressant trials. And it was beating the sham condition out to 6 weeks. There are studies that are going to come out showing that hot yoga has an antidepressant effect. There's studies showing that hot baths can have an antidepressant effect. And it turns out that hyperthermia, if I stick you in my fancy machine and do this to you, some of your inflammatory pathways skyrocket. They really get activated. The more they get activated, the more undepressed you get. And so this is really interesting because it sort of flies in the face of everything I just said. But the key thing here is that, like exercise, heat does not activate all the pathways that are activated, say, when you've got a bad infection. Heat only activates IL-6, this cytokine called interleukin-6, which, although it's inflammatory, also has the ability to kick off anti-inflammatory reactions. And so we
Through
think that
IL-10, right?
yeah, IL-10, exactly. And so we think that that's exactly right, that that's what's going on, that hyperthermia is sort of, it's sort of like lifting weights. You don't lift weights 24 hours a day, 7 days a week, but you lift weights and it tears your muscles down. And then there's compensatory rebuilding where they come back stronger. We think that what's going on is that the hypothermia, people live with depression are too hot because they can't shed heat. So instead of cooling them off, which would be the obvious thing to do, you apply more heat and it pushes the system, and then it kind of pops back into an overshoot state. And we think that these immune pathways have something to do with it because they line up with how much better people feel afterwards. So we have data that the antidepressant effect is correlated with how much of this immune activation any given patient gets. So it's interesting. I went into the inflammatory work because I was interested in body temperature back in the day. And it's interesting that then when we had a chance to get back into the body temperature, it led back to the inflammation and that whole immune story. So this is the beautiful thing about science, is that things that seem disconnected, if you follow the thread long enough, you get down to these sort of basic principles that are really cool.
Mm-hmm. So for those of you listening who maybe aren't as familiar with these different cytokines, as we're starting the conversation, it sounds like, inflammation is sort of the enemy, that it can make depression worse. But then what you were just referring to with comparing, whole body hyperthermia to exercise, is that it's more of like a hormesis that's occurring,
yes,
where you get exposed to to inflammation, really, in the case of exercise and in the whole body hyperthermia, to the degree that it sort of hits that it sets a switch off to go in the opposite direction through the interleukin 10 sort of mechanism that you're mentioning.
Bingo. Yeah, there you go, man. You did a better job than I did. That's exactly what we think. Yes.
And so, when people thinking about exercise, it really is an inflammatory, exercise you're putting yourself through, but it has these anti-inflammatory impacts later on after the exercise.
Yeah, exactly. It builds up resilience. It has, and interestingly, so with the heat, with the hyperthermia, in the study that we did in Switzerland, we did a good job of measuring 24-hour core body temperature. And I said, well, we really heated people up, but 5 days later, their average 24-hour core body temperature was much lower than it had been before. So it's hyperthermia, but the end result was a cooler thermal state. It fits exactly with what you're saying, right? That sometimes you got to push things the opposite direction to get them to go the way you want them to go. It's like driving a trailer backwards. Turn right to go left and turn left to go right. If you do it, all these sort of hormetic kind of, this idea that things that are really toxic in large or long-term exposures can actually be health promoting. You can build up resilience if they're administered in appropriate doses, in time limited way. They all follow this sort of U-shaped curve, where if you don't have any inflammatory signaling, and they've bred rats and mice that don't have inflammatory signaling, they're cognitively idiots. On the other hand, if you have too much, then you're going around with this sort of chronic inflamed state, and then you're in bad shape. There's some sort of U-shaped thing where if you hit the right sort of dose of some of these things. They really things that are things that are bad when they're long term and can be actually, positive. It's fascinating.
And so taking this together and somebody listening to this and they're thinking, I have depression and I want to, use this inflammatory pathway to make myself feel better, or for clinicians listening to this, what do
Yep.
you think are some of the, low hanging fruits out there of how to apply this practically? Or, if there are any things that are currently being developed, or kind of new things on the frontier that might be helpful.
Yep. Well, Um, so 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 let's talk about anti-inflammatory drugs, since that we started with inflammation.
Mhm.
Something that I'm not particularly impressed with actually is the evidence that anti-inflammatory pharmacologic strategies are really very promising for depression. I mean, I say this as somebody that, with my mentor, published the first paper actually looking at this sort of work. If you are chronically inflamed, um, and we give you a chronic anti-inflammatory, there's a signal. If you're not inflamed and depressed, forget it. It's actually bad for you. But if you're one of these highly inflamed people, but it's not a very robust signal. And anti-inflammatory strategies have their own risks. I'm a much bigger fan of this other way that we're talking about, hormesis. I sometimes call them adaptive stressors.
Mhm.
These more naturalistic ways of turning down inflammation and resetting the system. Exercise, classic example, and we've been talking about heat, which looks to be a classic example too. So, you know, I think that the data have come along far enough that encouraging people with depression or anxiety to try heat as a modality it's a perfectly reasonable thing. And to see the best effects, our study would suggest you do need to get pretty hot. But I've got a colleague out on the West Coast who is studying just regular old, the kind of infrared saunas like you can put in your house, or like you can go down to the beauty shop or the spa. And she gets people up to the same body temperature we did, and so there's no reason to think that they wouldn't have the same effects. As I say, there's one study of hot baths. This is almost certainly why hot yoga is so popular with people. I mean, why do people pay good money to do yoga in a stiflingly hot room? The answer is because heat is an antidepressant. So I think we should encourage our patients, if they have access to heat, to really give it a try and see, because the effects can be fairly long lasting, and many people have access to modalities where they can do it fairly regularly. And then sometimes, because of the work I do, people come up to me and say, I depend on something like a sauna, and I say, well, here's why so sometimes it's very comforting to patients to say, if you've noticed that you even just temporarily feel better after a hot shower, there's a reason for that. There's a total reason for that. And it's because through a bunch of mechanisms, heat's like a deep brain stimulator. So that is certainly something now that I think is very, very promising. And then there's other things on the horizon. I'm much involved in the world of psychedelics, which in their own strange way may well be psychological adaptive stressors. And that's a whole other topic, but that's also something that it may well be coming at us as a novel treatment modality in the next 5 years, 6 years, something like that.
Mm. Yeah, that's interesting. I haven't ever heard of psychedelics described in that way, as an adaptive stressor.
Well, yeah, but it's really interesting. So work done by, especially by Robin Card Harris, over at Imperial in London. When you look at, so the current treatment, unless you're a microdose, or the current treatment is, you take a high dose in a very controlled, therapeutically supported setting, and people have different types of experiences. Some people, have beatific, I'm one with the universe kind of stuff. But especially people with depression, a lot of them have these really excruciatingly painful confrontations with the trauma of their past or whatever that's with them. They're crying for hours. It's rough. But several studies show that the more that happens, the more undepressed people get later.
Mm.
But it's clearly a psychological, it's got that same sort of hermetic property in that,
Right.
you're not going to feel like that for 15 days. You're going to feel like that for 3 hours,
Mhm.
but it's going to be so damn intense that you can't turn your eyes away from it. And so you get this opportunity to deal with it. It really, it really does have some of that same kind of signature. It's a short-term treatment like the hyperthermia, and it produces long-term, at least in studies thus far, really long-term outcomes. So I do think that just as there are physiologic stressors that can be healthy in certain doses and certain durations, I think there's, psychological stressors that paradoxically, because stress is a bad deal. I don't
Mhm.
need to tell you that chronic stress kills us and makes us miserable, but it's that same weird paradox that, you give people a psychedelic, they have these unbelievably short-term stressful experiences that allow them to face things they don't want to face. And then afterwards, they do better for considerable periods.
Mhm. Yeah, almost akin to like hitting rock bottom.
Yeah,
People talk about in addiction recovery, and then
correct. Exactly. Yes, I think that's exactly right. There's a letting go. There's something that happens. You get down to a certain point and you're either going to give up or you're going to kill yourself or you're going to get a liberation and you're going to go, you know, when there's nothing left to lose in a way, there could be a liberation there. I think it's a very similar process.
Mhm. So going back to inflammation and and kind of what we can do with this and kind of where to go from here. You've recommended, or you've talked about whole body hyperthermia as maybe something that can be helpful for people. And you mentioned before some of the studies on obesity and maybe the role that dopaminergic medications can play in treating those patients. But I think that goes with the underlying assumption that treating obesity, trying to overturn obesity if you can be a powerful
Oh yeah.
mechanism in the treatment of depression. Are there other sort of pro-inflammatory things in people's lifestyle that they can focus on or turn around? I think maybe diabetes would be
Oh
something
yeah.
mentioning.
Oh, absolutely.
Mhm.
So the we've talked about these sort of short-term adaptive stressors, but there are also kind of longer-term strategies that just turn down the inflammatory chronic signal that seems to be such a depressogenic risk factor. And obesity is there's no doubt about it. I mean, especially abdominal fat cells, just they sponsor macrophage intrusion and they make inflammatory cytokines. And so definitely, I mean, there's a little literature, for instance, bariatric surgeries lowering depression scores, and you say, well, it's because they feel better about their body image. But yeah, it's a confound, but it could also well be that it's just that they're turning down this massive inflammatory stimulus. We eat too much in the modern world. I mean, there's like 10,000 different diets, but the one thing that's incontrovertible is that we did not evolve to consume the amount of calories that we do. I mean, let alone the types of calories, but
And
just the
as
sheer,
regularly as we do.
yeah, or as regularly, right? So I'm extremely interested in intermittent fasting. And if I had 10 lifetimes, that would be something that I would start pursuing. I don't know why I'm so interested in it, but I really am. And there's a little literature that's emerging out of that it also has, for many people, mood elevating properties and antidepressant properties. And it certainly has anti-inflammatory properties. There's some really interesting studies in healthy normals just showing that, 24 hours fasting turns off this thing called the inflammasome. So basically it turns off the head gate of inflammatory cytokine production in the body. It also has profound impacts on the microbiome. Uh, Fasting, very, very rapid. I remember this kind of the king of the microbiome, this guy named Rob Knight, telling me a couple of years ago, well, yeah, I mean, if you want to change the microbiome, the quickest, just fast. It really makes a difference. It tends to set up a less inflammatory microbiome. So these are controversial subjects, and I've got colleagues who very much disagree with this. But I kind of am interested in evolutionary sort of potential understandings. And of course, we know that we didn't evolve. We didn't eat the way we do now across human evolution, and we often went without food, and calories were always precious. And so, you know, our bodies over time just evolved to optimally function under those circumstances while developing brains to try to outfox the circumstances, right? So we've got this evolutionary mismatch where our consciousness has allowed us to, figure out ways to gratify all of our desires, which are very appropriate desires. If there's not, in the case of food, if there's not a lot of food around, not very many sweet things, the desire for honey is extremely valuable, right? But then the human culture invents, high fructose corn syrup, and that evolutionary drive is just leading us astray in a terrible way. So I think that there's a whole diet story. There's no doubt that there's a diet story that that we could be doing much more with in mental health.
Mm.
So exercise, diet. There's we talk about sleep. That's another one. Obviously, it's a big connection with well-being, and we know that there's been some sort of revisionist thinking lately about that maybe the modern world's not so different than sort of how our ancestors were. But one thing for certain, um, darkness is as healthy as light, and sleeping in a dark room, sleeping in a cool room, really can make a difference. Just day in, day out, it's just a really good health practice.
Mm. Absolutely. Going back to eating, I think that's something that's interesting to think about through the lens of inflammation, is about how, the role of our immune system is in one part to attack invaders, and that's what's happening when we're eating food.
Absolutely.
We have, a small measurable inflammatory response that's happening anytime that there's food inside of our bodies, because it is, seen by our bodies as sort of an invader. So,
Absolutely. Yes, that's right. It's a prepotent response.
mhm.
Food is, and there's like a number of thousands of people every year die of food poisoning eating at restaurants in the United States. I mean, it's not, yeah, food is dangerous.
Mhm.
It's absolutely dangerous. And so it extracts an inflammatory cost. It's really, you're exactly right. It's really fascinating. It makes perfect sense. Of course, you'd want your immune system to be on patrol when you've just, the immune system wants to be on patrol anytime you're trying to get something across one of the body's barriers. I mean, that's just the way to think about it. And so, yeah, so so basically giving the gut a rest, it makes a lot of sense that it's just a smart thing to do. And
Mhm.
of course, we know it's not as clearly established in humans, but God, in other mammals, caloric restriction is one of the ways to increase your lifespan pretty strikingly.
Mhm. Yeah, one thing I've thought about with fasting is about, that the that it sends your body partially into fight and flight response, in certain phases of the fasting, and whether or not there could be a norepinephrine, norepinephrinergic sort of mechanism behind the possible sort of mood lifting impacts of fasting. I don't know if that's been studied at all.
It has
Um,
been a little bit, and dopaminergic stuff too, right? So there are studies showing that cognition is sharpened, for instance, after a short-term fast,
mhm,
which again makes sense. I mean, if you just killed the mammoth and you're kind of glutted yourself, you've got to keep an eye out that the lion doesn't come and eat you, but you don't, but the next, but 2 days later, when you're hungry, that's when you got to start chasing down prey. You got to be looking. I mean, tracking and hunting gathering were very complex cognitive tasks, right? And so again, it makes very good sense that yeah, that um, you do get an activation of catecholamines, and that under certain circumstances, those can be very mood elevating. I mean,
mhm.
the fight or flight response can be very depressing, or under certain circumstances, it can be. I mean, manic people have massive fight or flight responses. It can drive affective state in different directions for sure.
And I think that sort of parallels the possibility of something like bupropion being more effective for obese people, in that, you get more of a benefit, you get sort of this lifting with the norepinephrine and the dopamine,
Hmm.
if you go into a fasted state, just like you would if you were taking bupropion
Agreed.
if you're
Yeah.
obese.
Yeah.
Um, well, very interesting. That one last thing I want to talk about with the lifestyle modifications is that you had I'd seen mentioned before that you speaking or mentioning or writing about bright light exposure as well as
Yeah.
part of probably through the lens of the importance of sleep
Hmm.
for depression prevention in particular. Could you just talk a little bit more about bright
Yeah.
light
Funny.
exposure?
I almost did that from my own side during our conversation about stuff. So I have always been a seasonal person. It's not been quite as much as I've gotten older, but when I was young, I tended to get depressed in the winter, and I'd get kind of all hopped up in the spring and the fall, and so I have benefited myself from a bright light. It's got to be like one of these special 10,000 lux lights. They're really quite effective for me, and they're really quite effective for many people. In fact, not just seasonal people. Actually, light is probably just generally an antidepressant. So yeah, there's a whole literature. I mean, we know for sure that the fading of the light with the onset of winter in people, we don't quite understand. We know melatonin's got something to do with it, and neurotransmitters. About 10% of the population tends to get a little woeful with cold, gray, dark weather. 1, 2%, would be clinically impaired. And so absolutely bright light works just as well as antidepressants for that, and with far fewer side effects, and with the advantage that you don't need to do it when spring rolls around. And so 20 minutes a day is generally does the trick. You want to do it in the morning. Studies show that it's more effective in the morning than it is at night, and that makes sense because light exposure in the morning is like what they call Zeitgeber. It organizes your circadian patterning
It sets
so
the
that
clock.
it sets the clock, right? It helps you go to sleep and get more slow wave sleep at night, right? And so the other thing I tell people, and I do practice this myself. I'm not always so great about wellness practices, but something that I'm pretty religious about is the grayest day outside is still 3, 4, 5,000 lux. I mean, the inside is like 100 or 200 lux, the sort of measurement of light. So just getting out in the morning, even if you live in Seattle in December, I mean, it sort of stinks, but it makes a difference. That and a bright light can often get people get you through it. It's really amazing. So yeah, and of course, same thing. Humans evolved to need light and dark are like vitamins for the brain. Darkness too, though. And there's a whole little literature, not nearly as large, but darkness has some real health benefits. So the combination, and it makes sense. The combination of those two things were mostly across human evolution. It was, except under a full moon, it was dark, and days were bright. And so, yeah, so absolutely, that is another very simple thing that can be done. There are good lights that you can get for, $100, $150. You don't have to totally break the bank. And I highly recommend it.